Now, we have bioreactors which are in our facilities, and our original size was based upon a 160-liter scale. So these are fairly sizable but small. We call them small bioreactors. And this is where we did the majority of our clinical studies in infants. Why we even choose infants at the beginning from a development standpoint is because of our overall supply was tight, and we were building up to do that. And we felt that that was an important group to initially address, and long term we would then roll it out to the adult population. So originally we have the 160-liter material that comes out of the product. This is currently licensed in the United States and is treating approximately 70 children in the United States right now. We're working with the FDA to go to this level and to scale up, because it's not just each product, it's the process that you need to get approved. In Europe and everywhere else outside of the US, we entered into the launch with approval of the 2,000 liters. So that was good. So we had enough data to support this, this scale here. But in order to meet the need worldwide and long term, we really need to move over to this scale here. This is kind of like a jumbo scale, 4,000 liter. And this is in development and on track, and we'll be eventually moving to this level here. So this is the long-term goal of how we're going to get there. So taking a look at what a bioreactor looks like, this is the 160-liter bioreactor that we have in our Framingham, Massachusetts scale. And just take a look at the size of the person here relative to the bioreactor and how it works. And this is just one piece of a huge, complex issue, but really is the main part where the CHO cells continually to produce myozyme in culture, and then it is then perfused off and then into harvest tanks and then filtered, purified, and then put into vials. So this is the 160-liter production. And this is our version of the Thames River. This is the Charles River in Boston. And this gentleman's practicing for the Henley, I think. And this is the Alston facility. And everybody in Boston thinks I work here. And I don't, as we have a business aspect. But because everyone thinks this must be a beautiful office to work in. You go inside of this office, it's a manufacturing plant. And by ordinance, we had to make sure we beautified the river and didn't have this industrial look on the river. So inside the shell of this, you'll see the 2,000-liter bioreactors producing myozyme. And this is, I'll just call for this term, a medium scale. And now the difference here is this cone has got a lot bigger, and the bioreactor at 160 was about this size. This is just the feeding cone into the bioreactor, which goes down into the second floor. So this is the top of it right here. And it's all fed by some tanks up top here that feeds, and it's a 4-story production of how this all works here. Now, moving on to the next level is the facility that originally was manufacturing the transgenic GAA, and in the acquisition of farming for this manufacturing plant, Genzyme converted this many years ago in preparation to bring us the 4,000-liter scale material. And now again, taking a focus here on the person here and the size of these feeder cones and this is another 4-story facility. We had the privilege of inviting the IPA board to take a look at this just more recently at the facility. So things are in place online to scale up, and we're very excited about this sizable manufacturing, and it's clearly the largest manufacturing that we do at Genzyme. Now, why am I even talking about all of this is a few months ago, we publicly made available that our supply is starting to tighten, and that the demand, the overwhelming demand for the product is such that we have to keep up and make sure we have adequate supply. And so things will be tight until this comes online, and it would be only a temporary tightness situation because we're well on track for EMEA approval in the first half of 2009, and we're very confident that that will come online and planning to do so. But we are at a point where we just need to just kind of watch things and monitor them and analyze the situation. We'll keep you informed on the process overall. So we just wanted to make sure you're aware of that. So moving on to one of the biggest priorities in the program, which was manufacturing, we moved into our overall programs. And once we had a manufacturing plan, and you can imagine the timelines that we've all moved through together over time, starting with the original natural history studies to support, if you will, a control group because of the ethics associated with placebo-controlled, to completing the successful infant studies, and then prior to approval, launching additional natural history-like studies, the late onset study, observational study, to help support the LOTS trial and understanding, and the Pompe registry beforehand, to then working with the Dr. Chomolis down in Argentina to help us really develop a rapid test of a blood testing. Dr. Cooper talked to us about the interfering enzymes and how you had to separate that up. There's a breakthrough technology that was made available, so blood spot testing. We didn't have to rely on skin fibroblast and muscle biopsies in order to make this diagnosis, which were not always reliable and were time-consuming and painful for the patients for sampling. This was an important breakthrough that now has taken hold throughout the world, and as technology gets developed. In 2006, we received approval for Myozyme. And in 2007, as we were trying to scale up in the United States, this from the 160 to the 2,000-liter product, that we were running also into some situation of bridging that. And we wanted to make sure that all patients in the U.S. continued to be treated. So we introduced this Myozyme Temporary Access Program of giving Myozyme free of charge to the adults. About 170 adults now are being treated in the United States until this period of time under a compassionate kind of clinical trial, more or less, to make sure they continue to have therapy and up until the point where we actually achieve this scale-up in the United States. We were very pleased, and we were all very pleased about successful LOTS data, which we'll hear more about today. And then yesterday, Dr. Jones introduced this CRIM status as an important predictor of outcome for infants. And if they do not make residual enzyme, that there are some kind of negative consequences of that, and he discussed that. But that's very important to understand how this product works and what the expectations are. And I would imagine that Dr. Krishnani will be speaking a little bit more about this today. And then along the way, working with Taiwan to really pilot a newborn screening program using this dry blood spot technology to identify individuals with Pompe that wouldn't have been identified until probably their surmise. And many of these children now have been treated very successfully with a high survival rate. And it's been very encouraging information that's now being available and has sparked interest throughout the world now to move forward to the next level of newborn screening.